Let's get straight into the core diagnostic algorithm for Step 2CK orthopedic questions. We are diving directly into the clinical logic you need to absolutely master musculoskeletal and fracture vignettes. Okay, here's the master clinical algorithm. These are the 5 steps you've got to quickly process mentally for every single trauma vignette on test day. Step 1, map the patient's age and mechanism. A fall in a kid means something entirely different than a fall in an osteoporotic senior, right? Step 2, pinpoint the location and immediately check if the stem says open or closed. Step 3, and this is literally where most points are lost. What is the neurovascular status? Step 4, suspect occult fractures if symptoms persist despite a normal initial X-ray. And finally, Step 5, what's your clinical objective? Is the question asking for immobilization, advanced imaging, urgent surgery, vascular stabilization, or maybe an infection workup? Lock this flow in. Section 1, Salter-Harris fractures and growth plates. Let's shift to pediatric patients, where the central vulnerability is that growth plate. Now, what's really interesting here is the progression from type 1 to 5. Any injury to a kid's growth plate can cause growth arrest and a persistent limb length discrepancy, so pay attention. Type 1 goes straight across the growth plate. Type 2 involves the growth plate plus the metaphysis. Type 3 hits the growth plate and the epiphysis. Type 4 goes right through the whole shebang, metaphysis, growth plate, and epiphysis. And type 5, that's the most insidious, a crush or compression injury directly to the growth plate. You gotta memorize these, because the higher the number, the higher the risk of permanent growth arrest. Section 2, Foch injuries, or a fall on an outstretched hand. Let's look at this classic mechanism of injury that's gonna show up repeatedly. This brilliantly illustrates how a single mechanism can trigger an entire cascade of distinct injuries. Depending on the exact angle and force, a Foch can cause scaphoid fractures, Colles fractures, ulnar styloid injuries, and acute carpal tunnel syndrome. But wait, it doesn't stop at the wrist. The force can actually travel up the arm to cause a radial head fracture, an olecranon fracture, a supracondylar humerus fracture, or even an AC separation or posterior shoulder dislocation. You always have to screen for these associated injuries. When the vignette gives you a Foch, your differential needs to instantly widen. So here's a highly testable scenario for you. You have a patient with a Foch injury, severe wrist pain right in the anatomic snuff box, but their initial X-ray is completely normal. What's your next step? The key clue here is that high clinical suspicion despite the normal X-ray. You're dealing with a suspected scaphoid fracture. That initial X-ray has notoriously low sensitivity, so no, you cannot just send this patient home with NSAIDs. This requires either immediate advanced imaging with a CT or MRI, or, more classically, cast immobilization in a thumb spica splint with serial X-rays repeated in 7 to 10 days. We do this to prevent osteonecrosis and non-union of the proximal segment. Now, if you do find a fracture and it's displaced, they get prompt open reduction and internal fixation, or ORIF. Looking closely at the distal radius, you'll see another major Foch consequence, the Colles fracture's classic dinner fork deformity. But look at the image on the right. See how closely the median nerve runs near that fracture site? You have an absolutely urgent, high-yield need to evaluate for median nerve damage and acute carpal tunnel syndrome in these patients. Moving up to the elbow, let's say a child has a posterior fat pad or lucency on X-ray after a Foch. That's a supracondylar humerus fracture. They'll typically show up with pain, swelling, and limited range of motion. Test day logic dictates your treatment purely based on displacement. If it's non-displaced, a long arm splint and sling will do just fine. But if that fracture is displaced, you are triggering definitive action, surgical reduction and pinning. The absolutely crucial point here is screening for specific neurovascular distractors before you lock in your answer. Think about it. With a displaced supracondylar fracture, those broken bone ends act like a knife. You have to specifically watch out for injury to the median nerve and the brachial artery, and be on high alert for the development of compartment syndrome. Section 3, Pelvis and hip trauma. Let's transition from the upper extremity down to high-impact injuries. First, we have to address pelvic trauma. Contrast the immediate, life-saving application of a pelvic binder for an open book fracture, which tamponades massive venous hemorrhage in an unstable patient, against the insidious, slow onset of a pelvic insufficiency fracture in the elderly. That older osteoporotic patient will have weeks of groin pain after minor trauma, and you diagnose it with an X-ray or MRI. Now, focus your attention on the femoral neck fracture on the left side here. This has a very specific, testable clinical footprint that you need to be able to spot instantly. If the vignette describes an older patient lying on the floor after a fall with a shortened, externally rotated leg, severe hip pain, painful range of motion, an inability to bear weight, and obvious X-ray abnormalities, you are treating a femoral Nike fracture. Because of the high risk of avascular necrosis, plus the massive morbidity of bed rest in the elderly, your goal is to get them to surgery for an ORIF or arthroplasty as soon as reasonably possible once they are medically stable. Section 4. Clavicle and stress fractures, two unique fracture categories that demand completely different clinical approaches. Let's start with the clavicle. We manage an adult middle third clavicle fracture conservatively with a simple brace, rest, and ice. However, you absolutely must rule out brachial plexus or subclavian artery injury with a careful neurovascular exam. Now contrast that with a neonatal clavicle fracture after shoulder dystocia or macrosomia. These newborns present with pain, crepitus, and an asymmetric moral reflex. Your treatment? Just reassurance, gentle handling, analgesia, and pinning their sleeve to their chest. Moving on to stress fractures, these happen from repetitive activities or abrupt increases in training, often combined with low bone density. The classic example is the second metatarsal. They present with gradual, localized point tenderness. Notice I said point tenderness, not diffuse pain like shin splints. And here's a major test day trap. They have notoriously negative early X-rays for the first 2 to 3 weeks. While these are mostly managed conservatively with analgesia and reduced weight bearing, you have got to identify high-risk fracture sites. If the question stem mentions a stress fracture of the anterior tibial cortex or the fifth metatarsal, that demands an immediate orthopedic referral because they have a super high rate of non-union. Section 5. Hardware infections and bursitis. Let's see how this builds into the complications phase, specifically infections and inflammatory conditions. Whether it's from hematogenous seeding, adjacent spread, or a direct inoculation from a compound fracture or an animal bite, chronic osteomyelitis is a massive risk for a patient with prior surgical hardware. You'll see persistent pain, swelling, a chronic wound, a sinus tract, or non-union. A positive probe to bone test is a huge red flag, but here is the critical sequence. Before you pull the trigger on treating this, you must get a bone biopsy for culture. Only after the biopsy do you proceed to the definitive management, which is surgical debridement plus a prolonged course of antibiotics. You also need to rapidly differentiate bursitis etiologies. You've got to spot a hot septic bursa presenting with painful swelling, erythema, and warmth, often after cellulitis, trauma, injection, or immunosuppression. That requires aspiration and antibiotics with or without drainage. Separate that from mechanical overuse. Olecranon bursitis is just posterior elbow swelling, treated conservatively. Pes answering bursitis causes medial proximal tibial pain, often linked to overuse, obesity, or poor mechanics. Just manage it simply with NSAIDs and quadriceps or hamstring rehab exercises. Section 6. Rapid Algorithm Summary. Let's lock in the foundational test day logic with a high-speed synthesis. Memorize this final mental checklist for every single MSK question. 1. Map the age and mechanism of injury. 2. Definitively hunt for those neurovascular red flags like compartment syndrome or median nerve compromise. 3. Respect the occult fracture and know exactly when to image again, like with the scaphoid. And 4. Confidently trigger the correct clinical action, whether that's an immediate pelvic binder, an urgent ortho referral for a fifth metatarsal, or holding off on antibiotics until you get a definitive bone biopsy. Master this logic, and you will absolutely dominate the orthopedic section of Step 2 CK.